Thank you, Professor. Now it is my pleasure to invite our distinguished Professor, Dr. Humayun, Head of Pediatrics Department at Shiv City Medical Hospital. With his extensive knowledge and dedication to pediatric medicine, he brings a wealth of knowledge to our institution. He is not only a leader, but a mentor, nurturing the next generation of pediatricians. Please join me in welcoming Professor Dr. Humayun.
Mr. Rahman, uh, we are going to have a very, very important workshop today, and this is something in which you would learn hands-on. This is something in the nursery that you come across day in, day out. I am extremely grateful to our worthy presenters, Dr. Professor Iqbal, who is a renowned pediatrician and one of the leaders in the field of neonatology, will be joining us shortly as the lead presenter. Dr. Skandar and Dr. Asif Siddiqui Saab have already joined us, and jaise pata hai, they have previously also been kind enough to conduct workshops with us over here. So during the time when Madam is not here, I'll briefly talk about neonatal respiratory physiology. And although the presentation contains some material which is not directly relevant to our topic today, I'll just quickly go through that, but I would show you a couple of slides that are relevant. And in that also, I would not take much time because I think the presenters over here, our guests, need more time and more elaborate discussion from their part. So as you know that neonatal period is a period which is a transition from a protected intrauterine life to an extrauterine life. And there are changes that are occurring to finally reach a stage of an adult human being. And so the neonatal physiology is not exactly, an anatomy of course, not exactly like the adult or the physiology and anatomy of an older child. So there are differences, and these differences have implications both for various diseases, their approach, their management, and one has to be a physician who's managing these young individuals should be aware of these changes. So we see a few changes that occur over the period of time. Now, briefly looking at the embryology, and I won't go in detail, just to tell you that it all starts from a pouch that develops around 4th week of gestation, and then it grows down and becomes a tracheal bud, and then this tracheal bud would ultimately form trachea. और ये आपको जैसे कि दरख्त बनता है तो दरख्त का तना होता है और उसकी टहनी होती है, ब्रांचेस होती हैं. So this would branch out. ठीक है? The tree stem is the generation 0, and the trachea is generation 0. So it would branch out, and that branches are various generations. And the end of the branch is the alveolar, are the alveolar sacs. So वो वहाँ पे terminate है. That is the place where actual oxygenation is happening and where the actual function of the lung is taking place. So at the time of birth, there are, depending on the exact gestational age, around 17 to 20 generations of these branches of the tracheobronchial tree that have formed. And the adult tracheobronchial tree has 23 generations. So there are a few generations more that still develop postnatally. So this is again the same. And in this slide, just forget about the whole details in that. In this slide, just want to show you that by week 27 to 23, surfactant is detectable in the amniotic fluid. So this is the time when surfactant is available. Now, what is surfactant? When you say surfactant and you are not a physician or a doctor or a medical person, so we use surfactants day in and day out. क्या होता है surfactant? क्या होता है? क्या होता है?
Sir, lipoprotein.
Huh? Is a detergent is something that at the interface of fluid and the air, it breaks down the tension, that is the surface tension. So even the detergent, the surf or the soap or whatever, not the soap actually, detergent जो surf वाला है, वो आपका ये होता है surfactant होता है. So such a surfactant is present in the lungs also, and that is a pulmonary surfactant. And this is there to reduce the surface tension, and it is a complex of phospholipids and proteins. इसका के actual जो scientific name है वो diapalmityl phosphatidylcholine है, DPPC, and what it has are two ends. One is a polar hydrophilic. जब हम philic बोलते हैं इसका मतलब one that loves. So hydro means water, so water loving head. So that is one which sort of attaches to the water, and then there is a tail which is non-polar and it is hydrophobic, and that goes towards air. This is water heating head that remains away. So this, when it is inserted into the surface of the surface of the fluid inside the alveolus, it reduces the surface tension. And this is produced by cells of the alveoli. In alveoli, you know that there are cells predominantly present which are called type 1 pneumocytes, and these are the cells that are responsible for oxygenation, for the exchange, gaseous exchange. And there are some cells, these are type 2 pneumocytes, and these have the responsibility of producing. And you know that there is a film of water on the inner aspect of the alveolus, and these surfactant molecules are interplaced on the surface, reducing the water tension, the surface tension. Because if these are not there, this surface tension would lead to collapse of the alveolus. Now, another thing is compliance. We use this word compliance day in, day out. So what is compliance? It is a measure of distensibility or the elasticity of the respiratory system. मैंने लफ्ज़ respiratory system इसलिए बोला कि मैं आगे कुछ इससे relevant बात करूँगा. And mathematically compliance is volume change, which is delta V, over pressure change, which is delta V, or in other words, volume change per unit pressure. So that is, if you change the pressure to 1 unit, how much volume is increased by that is what we call as compliance. And lungs which are more compliant are more distensible, and which are less compliant are less distensible. And to perform their function, lungs need to be compliant so that they distend easily, get in the air, which is responsible for gaseous exchange. So surfactant is a molecule, as I've already mentioned, which is responsible for the for this compliance of the lungs. So actually there is compliance of not only the lungs but also the chest wall compliance. ठीक है? और जो lung की compliance है is because of surfactant, and this is less in the newborns as compared to the compliance of older children or adults. And this is because the newborn at the time of the birth has a lungs filled with the fluid, and that fluid has to be removed from the alveoli to make it compliant. और वो क्या है, वो मैकेनिज्म जो है, एक तो जब जैसे बर्थ कैनाल में से निकलता है स्क्वीज होता है बेबी का नाम, और वो फ्लूइड बाहर निकल आता है, फिर भी कुछ फ्लूइड रह जाता है, वो बेबी कैसे निकालता है? By autopeeps. And what does the baby do is that on the closed epiglottis, the baby generates pressure, and that pressure reaches to about 35 centimeters of water, which leads to recruiting of waterlogged alveoli, और उस pressure से जो fluid निकलता है. But we cannot compare actually the compliance of the newborn to the compliance of the adults or an older child. जब मैं लफ्ज़ adult बोलूँ तो इसका मतलब है older child also. There is a term which is called specific compliance, and that specific compliance is we can correlate the adults and the newborns. So what is specific compliance? It is indexed to the functional residual capacity, which in neonate remains roughly proportional to the adult. ठीक है? जो residual capacity है, या आपको अगर volumes और capacities जो नाम की हैं वो याद. The second thing is that the thoracic cage and is also has its compliance, its elasticity. Whereas the lungs are less compliant, the thoracic cage in the newborn is more compliant, more elastic, and that is because of cartilaginousness of the thoracic cage. The ribs are cartilaginous in the newborn, makes them soft. And this compliance is counterproductive because when negative intrathoracic pressure is generated, these need to be sucked in. ठीक है? तो these get sucked in, sorry. तो ये by first year of life जो इसकी compliance है वो कम होके वो adult है. तो ये बात समझ आ गई कि compliance जो है जो thoracic cage की है वो फायदा नहीं दे रही है, क्योंकि ये बहुत इसकी सॉफ्टनेस जो है वो with the depth of respiration it's sort of sucks in. So what you know is that the breathing has two things, depth of respiration and the rate of respiration. So that is why the newborn relies more on the rate of respiration to have an effective respiration. So वो compensate कैसे करता है उसको? वो compensate करता है ज़्यादा breaths लेके, that you know that at various ages. The second thing that is relevant to this workshop probably is the differences in airways, and these differences would have some implications. So what are these differences? That there is a small mandible in the newborn, there is a relatively large tongue, so in proportion. There are large tonsils and adenoids, and the larynx is in a superior position. ठीक है? ये जो larynx है ये superior position है. There is a soft, narrow and short trachea, which is, as the larynx is superior, so trachea is also superior, and very important is that epiglottis is proportionally longer, narrower, larger and less flexible, and often it is omega shaped. ये है newborn का, ठीक है? As compared to an adult epiglottis. And these the functional implications of these anatomical changes are that there is problem of intubating the neonate. So your neonatal intubation has its own way rather than how you intubate an adult. So वो इसकी वजह से है. And with very negative and very positive intrathoracic pressures, the soft airways will not resist collapse and stridor may ensue. These are the clinical implications of. So further on, I'll very quickly go through these slides of the neonatal physiology, probably not very relevant. This is the airway resistance. Is that airway resistance is more in the young as compared to the adult, because resistance is a function of the radius of the air passages, and there is a law which is called Poisson law, इसको L नहीं pronounce करते, or equation in which the resistance is inversely proportional to force of raised to power 4 the radius. So radius को अगर 1 जो है यूनिट कम करेंगे तो जो resistance 4 times बढ़ जाएगी, ठीक है? So this leads to higher air resistance in the smaller passages in the young. ठीक है? So lung volumes are also different in the newborns, in the neonates. Some of the reasons are that the ribs are horizontal and diaphragm is more flattened. So normally the adult or the older children's ribs are obliquely placed and a diaphragm is dome shaped. So this has more capacity to increase in the volume of the lungs. When the ribs are straighter and the diaphragm is flattened, this leads to a disadvantage in increasing more negative intrathoracic pressure. However, the functional residual capacity is similar to adults as we see in the model. The tidal volume per unit tidal volume is all the same. Although the tidal volume of the newborn would be very, very small, but both the tidal volume of the adult and the newborn is 6 ml per kg at rest. See? But the problem is that the newborns have more anatomical and physiological dead space. So more of this tidal volume, which is the same, is lost by that increase in. How does a newborn compensate for that loss in anatomical and physiological dead space? Is by increasing the rate. वो रेट बढ़ा देता है ताकि उसकी ऑक्सीजनेशन जो है वो एडिक्वेट हो जाए. And these are the various lung volumes and capacities. So you can see that the tidal volume per unit kg is the same. However, the rest of the volumes are different. Some are less and some are more. The residual volume and closing capacity. Closing capacity क्या है? Is the capacity at which the alveoli starts closing down. ठीक है? So वो ज़्यादा होती है न्यूबॉर्न में. ये वही चीज़ है. ये किसी को कहता हम डिटेल में सेपरेटली कर लेंगे. अभी हम चूँकि बहुत रेलिवेंट नहीं है इसके लिए तो लोजी. I welcome Professor Taiba Awad और ये जो है she has been very kind to न्यूनेटोलॉजिस्ट हैं, इन्होंने अपना जो न्यूनेटल यूनिट सर्विसेज के अंदर इस्टेब्लिश किया है इज़ वर्थ सीइंग, एंड I would like you guys to go over there. We have, madam, many fourth-year residents who are about to leave our ward, and I would request you to allow them to sometimes come and attend your morning meetings, so that you are also enlightened by our knowledge. Before your coming, I briefly talked about the neonatal respiratory physiology, and I would now request you to come